Welcome to the future. PBS Digital.
582, medic 43, engine 32, chest band, 710, guest.
Every 30 seconds, an American suffers a heart attack. 40% of them will die within a year.
Yeah. Chemstrip 190.
Each year, coronary heart disease accounts for almost 1/3 of all deaths in the United States. As baby boomers reach middle and old age, heart disease is threatening to become a national epidemic, one that already is beginning to strain the healthcare system to its limits. Americans are now spending $60 billion a year treating coronary heart disease. Add to that lost productivity, and the cost climbs to $118 billion. There's a growing body of evidence that indicates exotic surgeries and high-tech procedures are not the most effective treatment, and definitely not the most cost-effective. Innumerable trials and studies are proving that an innovative, non-surgical approach can not only stop the progression of heart disease, it can actually reverse the disease process. Despite mounting evidence, mainstream medicine has been slow to accept this revolutionary concept. But it is beginning to happen. Around the world, pioneering cardiologists are demonstrating that coronary artery disease can be successfully treated without surgery and at a fraction of the cost.
Major funding for To Heal a Heart is provided by Universal Computer Systems, with additional funding from Rensis, providing PC and audiovisual technology rentals for special projects, trade shows, and disaster recovery services.
This is the flow of life. Each surge delivers life-sustaining blood throughout the body. During a lifetime, a human heart will pump more than 60 million gallons. To fuel its relentless work, the heart is totally dependent on blood supplied by a handful of small arteries. These vessels spill over the top of the heart, reaching down into the pumping muscle. The first anatomists were struck by the symbolism. The organ they knew to rule over life and death bore a crown of these arteries, in Latin, a corona. These are the coronary arteries. There are three main branches. This is the largest, the left anterior descending. Doctors have nicknamed it the Widowmaker. If anything interrupts the flow of blood here, the heart shuts down. Blockages in the coronary arteries kill more people than any other cause, more than war, more than famine, more than any other disease.
You having pain right now?
These blockages are especially prevalent and lethal among Americans. Not only is it this country's leading cause of death, it's treacherous. In most cases, heart attacks strike with no prior warning. Typically, the disease isn't evident until the coronary arteries are severely damaged. In the majority of cases, the first symptom is a massive heart attack. It was the Korean War that provided the first real insight into the disease and its etiology. In treating casualties, Army doctors began to notice early signs of the disease in a large percentage of the young men who had been killed in combat. Even though their average age was under 25, more than half of them had significant blockage developing in their coronary arteries. The Korean War findings put coronary heart disease in a completely new light. It was not a natural consequence of the aging process. It was a progressive disease that started early in life.
This was very important data for scientific data for those of us that were interested in this area, because it means that it starts early. And we kind of knew that, but this really puts it home. That means if one can look early, treat early, prevent all that, that's really the conceptual basis for beginning to look at coronary disease in a different way than the mechanical one.
Lance Gould is a researcher and clinician at the University of Texas Medical School in Houston. He has devoted most of his 30-year medical career to studying the anatomy and function of the coronary arteries. His work has convinced him that the early detection of coronary heart disease could prevent most heart attacks.
Over the years prior to having the heart attack, there's been this cholesterol buildup along the lining of the arteries. And so in this little artery with the cholesterol buildup, it's open, there's lots of blood flow up until the point in which the cholesterol plaque breaks loose and in a sense falls down into the lumen of the artery. The blood comes in contact with the cholesterol, clots, and that clot blocks it off. All that process of plaque rupture occurs within minutes to seconds. But before that time, the arteries were wide open. And so the commonest manifestation of heart disease is a sudden event, sudden heart attack, sudden chest pain and instability, whereas the disease was actually present there for years before.
Dr. Gould wrote one of the leading textbooks on coronary artery disease. His research and numerous publications have put him at the forefront of a growing revolution in the field of cardiology. Writing in the American Journal of Medicine in 1998, Dr. Gould told his colleagues that the evidence indicated the time had come to shift from surgery-based, after-the-fact procedures to drug therapy and lifestyle modifications aimed at reversing the disease process.
In my opinion, much of the invasive procedures are done kind of as a routine. People have coronary disease, so they get these procedures, when in fact, as an individual considered, they wouldn't need them. And so it's important to realize that I'm not just anti-surgery, anti-arteriography, anti-invasive procedures. Rather, I respect them profoundly. I respect the body profoundly, and I'm convinced, based on scientific data, that there's an alternative, and that's what this is all about.
John Tomerlin is one of more than 12 million Americans with diagnosed coronary heart disease.
He had a history of an MI in May 96. They treated him with TPA and had an angioplasty.
In 1996, at age 55, John Tomerlin had a heart attack. Doctors determined that 2 of his coronary arteries were severely blocked and used a balloon dilation procedure to reopen them. After 5 months, there were signs that the blockage was returning.
Okay? Let's go ahead.
For the past 4 years, Tomerlin has been in a revolutionary treatment program aimed at controlling, hopefully reversing, his disease. Today, he'll find out. At the center of Dr. Gould's alternative treatment approach is the positron emission tomography scanner. He spent the past 20 years developing a specialized scanner that could produce detailed three-dimensional images of the blood flow to the heart. Cardiac PET scans are now considered the gold standard for assessing coronary artery function.
The magic, in simple words, is we look deep into the heart, to the arteries, in a way that's never been possible before. We have the knowledge that's never been available before, and we have the powerful tools to fix what's wrong that's never been available before. So we're really on the edge, and that's what keeps me awake. Okay, we're giving you tracer now.
An injection of a small amount of radioactive trace elements allows the PET scanner to follow the blood flow through the coronary arteries.
This is the important part where we take pictures of what's going on.
The first set of pictures is taken with the heart at rest. But the real test of the arteries is to see how they can perform under stress.
Okay, we're going to do stress now.
Okay.
This is accomplished by injecting a drug that simulates strenuous exercise and signals the heart and coronary arteries to achieve maximum blood flow.
And it will increase the blood flow in your heart about 4 times baseline, much higher than you'd ever get with the hardest exercise. Whatever the change is in your coronary arteries, it will impact the flow. We take a picture of it, and we can tell what your status is and where you're headed, particularly compared to last time.
The ability to delve deep within the human heart and view the function of coronary arteries has had a profound effect on Dr. Gould. It has given him a unique perspective on the disease and his patients.
The coronary arteries are really a magical part of the body. Although the arteries are strong and people can live a long time, they can also potentially be very delicate. They can be damaged by what we eat, what we do. And so in a way, how we live, who we are, what our identity is, what our standards are, they can affect these arteries. And so the arteries then become a marker of life, how we live, what happens to us. Well, John, we're going to look at your pictures. We'll keep our fingers crossed. This is the part that's really an unknown. We're going to show you the comparison between the 96 pictures and then the current pictures. So let me explain what you're going to see. Your heart sits in your chest like this, and we're going to take it out and lay it on the screen. So the shape of the heart is the shape you see on the screen. That's the sac of heart muscle that pumps like this, and it's the picture of the blood flow in the heart muscle sac. And the color scheme is white, red, and yellow would be good blood flow. Green and blue would be low blood flow. And this is your stress picture now in 1996, and this is your stress picture today. So in 96, you had this on the front of your heart, in this view, you had this really large, severe, abnormal area of impaired blood flow that actually went all the way up to the top of your heart. It's just kind of yellow at the green, and this is severe blue. And you're dramatically better today. There's a lot more red. There's a little bit of residual narrowing left, but not bad. And you really have improved tremendously. In this view, when a person with this heart problem actually sees these pictures, sees these images, and understands them, they become a powerful tool. Just wake him up, and he sees his life in a different way. He sees his future. He sees his survival or not. And so then he starts to look at food in a different way, his physical activity, his medications. All of a sudden, he's viewing life, what he does, through a different set of eyes, because we put into his brain an image of his own heart. That's not been possible before. Now we can do that. People understand that, and they react, they respond, and that becomes an essential part of treatment.
Since the very beginning, images have played a key role in the fight against heart disease. A major breakthrough came in the late 1950s when doctors devised a way to inject opaque dye directly into the coronary arteries. The resulting X-ray images could reveal the size and location of obstructions to the flow of blood to the heart. These images, coronary arteriograms, opened the door to the first effective treatment for coronary heart disease. In this procedure, a small catheter is inserted into an artery in the arm or leg. Guided by fluoroscopic images, the catheter is threaded through the arteries back to the heart. It is positioned in the aorta, at the origin of the coronary arteries. An opaque dye is injected as an X-ray camera rolls. As the dye momentarily fills the artery, a picture of the inside, the lumen, is produced. The image reveals narrowings or irregularities caused by a plaque buildup in the artery wall. Coronary arteriography has been a major breakthrough, allowing doctors for the first time to see the location of a blockage within an artery. 1.25 million of these procedures are done in U.S. hospitals each year, and the number is steadily climbing. Once blockages in the arteries could be located through arteriography, a treatment for coronary heart disease finally appeared to be possible. Houston heart surgeon Michael DeBakey, who was the first to remove obstructions in the carotid arteries, began looking for ways to do the same thing in the coronary arteries. He began experimenting with animals, trying to find alternative ways to supply the heart with blood when the coronaries were diseased. At about the same time, Dr. Rene Favillaro at the Cleveland Clinic was working with blood vessels taken from other parts of the body to form a detour around a blockage in the coronary arteries. In 1967, Dr. Favillaro performed the first coronary artery bypass using a section of vein from a patient's leg. The patient died not long after surgery, but the procedure itself was promising, indicating coronary heart disease was treatable. Later that same year, Dr. DeBakey performed another coronary artery bypass, opening a new era in medicine.
But we weren't quite ready to go into humans because our results showed only a 50% survival expectancy at the end of 6 months. But we had a patient who had a coronary occlusion and required an operation. But in trying to perform the operation, as sometimes happens, we virtually had destroyed the artery. And we realized that the only way we were going to get him off the table alive would be to restore circulation to the heart, and therefore decided to do what we've been doing in the dog and the animals. We went down and got a piece of vein out of his leg and did the bypass. And we were very gratified by the fact that his heart recovered, and he recovered successfully after the operation.
During a coronary artery bypass, surgeons take a blood vessel from another part of the body and construct a detour around the blocked part of a coronary artery.
See the yellow plaque? That's the first sign of atherosclerosis, is a yellow streak. It's cholesterol-laden plaque.
One end of the vessel is sewn into the aorta, the large artery taking blood from the heart. The other end is attached or grafted to the coronary artery below the blocked area.
Big artery, coronary artery, back of the heart. This is the circumflex marginal, and the blood's going through it now, so you can see fill the artery. Okay.
Blood can now use this new passageway to flow to parts of the heart that had been shut off. For most of the 60s and 70s, the standard course of treatment was a treadmill test, arteriography, and bypass surgery. It's a complicated and expensive procedure. The average cost is between $40,000 to $50,000. In spite of the expense, bypass was the only known treatment for coronary heart disease at the time. It worked and it was relatively safe. It quickly proliferated worldwide. Within 15 years of Michael DeBakey's daring surgery, the number of bypass operations exceeded 75,000. Houston heart surgeon Denton Cooley had personally performed more than 11,000 of them.
Well, it was the first true direct type of treatment. And in those early days, I think we probably did more bypass operations than any other institution or group in the world. The role today is quite firm. We believe that there are certain cases that we can identify now, and that those cases are only correctable with the bypass technique. By and large, a patient who has severe angina pectoris or chest pain, he knows that something needs to be done. And it's a very distressing symptom for these patients. They can only get maybe temporary relief by popping pills in their mouth, such as nitroglycerin, but they have that constant worry that they don't know which one of these angina attacks is going to be the major heart attack that leads to their death. And so to just relieve the symptoms of of coronary insufficiency is certainly an adequate reward for the patient to undergo some definitive type treatment.
That artery just looks terrific. Looks terrific. Got a new artery there. How are you feeling?
In the late 1970s, there was another breakthrough in the treatment of coronary heart disease. It was an advancement based on the cardiac catheterization technique used in arteriography. The procedure is a less traumatic and less expensive alternative to bypass surgery for patients with certain types of disease.
This gentleman is around a 60-year-old man who has severe diabetes and has had for many years. You know, he complained of being short of breath, and they did a cardiac catheterization, and there was a severe lesion on the artery going to the front of the heart, one of the major arteries. And if we find, in fact, that he does have this severe blockage, we'll be able to go in with a little tiny drill and drill through the hardened artery, the hardened blockage. In diabetes, they frequently have a buildup of calcium, so it's almost like bone trying to go through there. It's a little safer to use a little drill first and then a balloon and put in a stent to prop open the artery.
The procedure uses catheters tipped with miniature balloons. It's known as an angioplasty, or a balloon dilation. The sausage-shaped balloon is positioned across the blockage. The balloon is inflated, pushing the lesion aside, restoring the pathway.
This machine is called the rotablator, and it literally is a diamond-tipped drill that we will actuate at around 200,000 RPM to try to open up that artery. So now you can see the little burr approaching. Tap. Tap. Is the rear pro in? Tap. Tap. Push. Push. Stop. Okay, let's go. So we're slowly going down, still hesitating a little bit. Feeling all right? Okay, things are going well. So now you can see that the artery's already opened up, and that's just with passage of this burr. What we've done is we've taken out the original wire, which is very, very thin and flexible, which allows the rotablator to go easily into the artery, and we're replacing it with a stiffer wire, which will allow us a good platform for advancing balloons and stent devices. If you look, this is a little balloon. It's very, very narrow, very slick. And then when we get it positioned in the right position, we'll be able to inflate it and stretch open the vessel. Now we're going to take the balloon all the way to the tip of the ventricle. Does that look like a good position? Okay. So we have the balloon positioned across to where the lesion was. Go to 2.
Inflating.
4, 6, 8, 9, 10, 11, 12. The numbers are the pressure. The higher the pressure, the more force against the artery. Look at the distance between the balloon inflation, Greg, and the calcium. See the line?
Yes.
All that's plaque. So the artery is just full of plaque. Down. Okay, let's add the velocity, please. Play it back. Much better.
The results of angioplasty, though, are not as dependable as those from bypass. Arteries that have been forced open often have a tendency to close up again. Studies have found that in 20 to 40% of angioplasty patients, the blockage returns within 6 months.
The re-narrowing process in the artery, once you stretch it open, used to be around 30%. Now, with stents, the restenosis process has dropped further down to 10 to 15%.
A fairly recent innovation is to add a wire mesh tube, or stent, to prop the artery open after the dilation.
The sparkly material is the stent that's mounted on the balloon. And we'll advance that into the place where we dilated and expanded, and then that will serve as a scaffold to hold the artery open. And we're pushing the stent into the region that was narrowed. So shall we go a little more deep? There we go. Spit. How's that? Go to 2.
Deploy.
3, 4.
When the balloon is inflated, the stent expands, remains in place, and forms a rigid support to hold the artery open.
We're taking the stent delivery balloon out.
SDC.
We're going to go ahead and pull the wire out and take one final picture.
Guide wire DC.
Play it back. I think the artery just looks terrific there, doesn't it?
Although bypass is still the most frequently used procedure, the number of angioplasties has increased by 200% in the past 10 years. It's estimated that there are now 500,000 balloon dilations performed in the United States each year. Even with stents and other improvements, balloon dilation procedures have a high failure rate. Several recent national studies have concluded that long-range outcomes from bypass surgery have been equally discouraging. They reported that there was no significant difference in survival between those who had the surgery and those who did not. The long-term problems now apparent with bypass and angioplasty do not mean the procedures don't work. They do work. They save lives and they improve the quality of life. But they do nothing to arrest the underlying disease process, which will continue to take its toll.
Once you have the disease, it's unlikely that one procedure will be the only procedure you need. For some people, it obviously is, who take very good care of themselves and who don't have the problem of additional re-narrowing of the vessel that you've worked on. Others you can anticipate seeing, sometimes every 2 or 3 months, depending on the situation. In general, it's not unreasonable to expect a return visit in 5 or 6 years for another vessel or some other problem.
The obvious problem with both angioplasty and bypass is that while they can save lives in a critical situation, they do nothing to arrest the underlying disease process. Bypass can buy extra time for a patient and improve the quality of life, but long-term studies have shown that it does not significantly prolong life. In fact, the surgery itself is proving to have some major drawbacks. One of the most serious is a widespread decline in the mental abilities of bypass patients. A recent study at Duke University found that 42% of these patients show a significant drop in scores on mental tests 5 years after surgery. Some investigators attribute the decline to the prolonged exposure to anesthesia during bypass, or just the stress of a radical surgery. One theory is that the heart-lung machine, which takes over while the heart is stopped, could be pumping minute air bubbles or fatty deposits that eventually lodge in the brain. In response, many surgeons are now avoiding the heart-lung machine whenever possible. They are using a new technique to bypass a coronary artery without stopping the heart. About 20% of bypass surgeries are now performed this way. After decades where surgery was considered the ultimate treatment of coronary heart disease, a growing number of doctors and patients are beginning to look for alternatives. "15 years ago, this group of medical pioneers produced a major breakthrough in the treatment of coronary heart disease. They were all suffering from advanced stages of the disease. Werner Habenstreit was 71 at the time. His angina was so severe he could barely cross the street before the pain caused him to stop. He agreed to participate in the Lifestyle Heart Trial, an experimental program being conducted by Dr. Dean Ornish.
After 2 heart attacks, I had the feeling this is the end, it doesn't work anymore. I was a skeptic. My relationship to the medical profession was not a very pleasant one. And I didn't believe a word he said, but I was so sick that my motivation was, what do I have to lose? Perhaps there's something to it. Let me try it.
Dr. Ornish wanted to see if dramatic changes in lifestyle could affect the course of coronary artery disease. Few bypass patients exercised, Dr. Ornish noted. Most were out of shape, smoked, and were overweight. He began to wonder if their similar lifestyles played a part in their disease.
I started reading the scientific literature and got, mildly obsessed with what I was finding, because it was clear that in animals, in dogs and cats and pigs and rabbits and monkeys, you could cause them to get heart disease by making them smoke, by putting them on high-fat, high-cholesterol diets, by not letting them exercise, by putting them under emotional stress. And you could reverse it by changing those same factors.
He took a leave of absence from medical school and asked his professors to send him subjects for a simple short-term experiment.
So we took, in many ways, the sickest patients who, in many cases, had been out of work for years, who literally couldn't walk across the street without getting severe chest pain before the light changed. And by the end of the month, most of them were pain-free. And again, we could actually measure that they not only felt better, in most cases they were better. Their blood flow to the heart improved in ways we could actually see.
In the early 80s, after completing his medical training, Dr. Ornish relocated to the San Francisco area to follow up on his encouraging early experiments. He began recruiting patients for a longer term, more controlled study. 48 volunteers agreed to eat a low-fat, basically vegetarian diet, to exercise, practice yoga, and attend group support sessions. The results of the year-long study were dramatic. Participants' weight and cholesterol levels dropped, and their pain began to disappear. The most significant result was a measurable decrease in the amount of blockage in their coronary arteries.
We actually flew our patients to Houston for cardiac PET scans with Dr. Gould. We found the blockages got less after a year in the people who made the intensive lifestyle changes. But equally important, we found that the comparison group, who were making the more moderate changes that many agencies have been recommending, a 30% fat diet, got worse. And those differences were highly significant after a year, and we published that in The Lancet and later in some of the cardiology journals.
Impressed by the results, the National Institute of Health funded the Lifestyle Heart Trial for an additional 4 years.
And what we found after 5 years is that there was, on average, even more reversal than after 1 year, whereas in the comparison group, they actually got worse and worse. So instead of getting worse and worse, which is what usually happens to people who have heart disease, we found that on average, most people could get better and better. And I think these findings are giving many people new hope and new choices that they didn't have before. It empowers people with information that can really make a difference in their lives.
Ornish's Lifestyle Heart Trial was a major turning point in the perception and treatment of coronary heart disease.
This was basically a paper that reached down and appealed to everyone, not just the medical professions. And I think that was an important point. Now, what's evolved from that are a number of studies utilizing drugs to control cholesterol that are really very good studies. There are many of them, 30 of them have been done since 1990. And that's also been impressed upon people. And now I think the attitude that our people are getting is that it takes both. It takes intense lifestyle change. It takes aggressive pharmacologic intervention, vigorous treatment, because this disease is a killer. And you got to do everything you can to prevent it and reverse it. But the idea of self-determination, the intense control of lifestyle factors based on one's own motivation, that's a very important point.
In the early 90s, a Scandinavian clinical trial found that a new type of drug called a statin could significantly lower both blood cholesterol levels and deaths from coronary heart disease. The ability to use medication to control the levels of blood cholesterol gave doctors a powerful new treatment tool.
And it really works. The results are dramatic. They're not always 100% predictable in an individual, in large part because of the interaction between lifestyle and drugs. Drugs can do a certain amount, but then there's a lifestyle effect that can counteract the taking of drugs so that they work very well. But now we're beginning to realize that it takes more than just drugs. You just can't cure the problem taking a pill and go out and eating like a pig. It doesn't work. If you want to get 90% the problem solved, you got to do both.
Though the approach is different for each patient, there are some universal Gould guidelines.
Caloric load has got to be balanced out so that one doesn't become overweight. I mean, that's a basic given. Now, how you get to the point of controlling your weight, everybody's different. The second is that the food needs to be reasonably low in fat, enough vegetables, enough protein, enough carbohydrates or calories to balance out the weight, and somewhere less than 20 grams of fat a day, preferably 15 grams, but that's a little bit variable, but a limit. And then a certain amount of exercise, keep yourself lean, and working and limber. And then for certain people with the genetic risk or the actual disease, the drugs. I mean, that's it. And in many ways, this is nothing new. We've known this a long time. But the difference is that we can see it. We know what it does to the heart blood flow. We know the kind of intensity it takes. More importantly, we know that when you do it right, it fixes the problem.
PET scan has given Lance Gould a unique insight into coronary artery disease and a simple but revolutionary treatment approach.
It's a new kind of medicine that's not just be good, don't eat too much, and kind of hope things come out, but it's very specific. We take a picture of you. We know what you have. We know what's going to happen to you, and then we do something specifically to control it, to prevent it, to reverse it before some big disaster occurs. That's a new kind of medicine. Good morning, Jim.
Good morning.
How are you?
Good to see you.
Welcome.
Possibly the most revolutionary aspect of Dr. Gould's treatment approach is his view of the doctor-patient relationship.
The patient has to decide, does he want to take this lifestyle change into his own hands? Doc can't make him do that. So the real change is active patient participation and a doc being a consultant and a guide, and together they solve this problem rather than the old-fashioned way of the patient being fairly passive to a fairly godlike doctor that tells them what to do.
Is it kind of working? You feel good about it?
Oh, much better. Much better. New person. New lease on life.
Okay.
Dr. Gould admits that his are unusually motivated patients and that it is their involvement and active participation that determines a good outcome. Many doctors have traditionally shied away from the treatment options that depend on patients making difficult lifestyle changes.
If you look at these things, these anecdotes about some individuals who have bypassed the bypass procedure, you know, by modifying their lifestyle, that those things are valid. But these patients often have to modify their lifestyle to an extent where they might be partially disabled. Many of the patients that we see want to be back into an active life where they don't have to worry so much about their diet and their overactivity and so on, their stressful sort of environment that they have. They want to be able to be active and not be concerned about the possibility of some disaster hitting them.
In patients who are willing to make a wholehearted commitment, the results are impressive.
They're all surprised that it works so well. They're all surprised that you can actually control your food and lose weight, enjoy life, and not be hungry. You can take some medications, and you feel better. You feel more energetic. If you have coronary disease, the chest pain goes away. And if you get a PET scan and you've got early disease, like because of family history or whatever, you can actually watch it go away. This is a tremendous motivation. So the bottom line is that the vast majority of people can do this, and it actually works, and they get better, and they don't need surgical procedures, and they don't have heart attacks. Keep it up. And if there's any problem, call me.
Okay.
But congratulations, you're there.
He's a pioneering genius, a heart man who has a heart and soul, who is vitally interested in seeing that his patients understand their disease and helping them recover from that disease. He's a gift from heaven.
Cleveland industrialist and philanthropist Al Weatherhead is one of Lance Gould's patients. He also is one of his most ardent supporters. At 75, he is more active than most men half his age. He had his first PET scan 10 years ago following a heart attack. It revealed a 90% blockage in one coronary artery and about 50% in another.
This is the PET imaging for Mr. Weatherhead, showing what his heart was like when we started this program. This is a very abnormal picture showing fairly severe coronary artery disease in large segment of the heart. Very visual, very personal, and a real problem. This is the disease that kills people.
Faced with irrefutable evidence of his disease, he decided to turn his life around. It wasn't long before a second PET confirmed he was on the right track.
90 days later, I was there and had a second PET scan, and there was mild improvement. And that was an awakening, a call from heaven. Now I see evidence, clear, proven evidence that there is a reversal, albeit small. Now I'm on the right track with exercise, with meditation, with the proper diet, with beginning to open my heart to people and just help them out.
Like many of Dr. Gould's patients, Al Weatherhead has found that his PET images are always with him and provide constant reinforcement as he pursues the healing process.
One of the things that I do when I cycle, I take a mental trip through my heart and I explore every single artery and every single vein and every capillary. And I inspect those very carefully to see the success of my heart reversing program.
Over the years, Mr. Weatherhead's follow-up PETs revealed a dramatic picture of coronary artery disease and steady reversal.
It really demonstrates in a very nice way what it's possible to do with the right kind of food, the right kind of meds, the right kind of discipline, weight control. This is a picture of reversal of coronary artery disease. This is a picture of survival.
It's inspirational to see with each succeeding PET scan that yes, you can accomplish anything you want in life. Any individual can do that.
After 10 years of steady improvement, Al Weatherhead is a true believer. So is his wife Celia, who also is on Dr. Gould's program. Together they wanted to do something to make this alternative approach available to the millions who need it. In 1997, their Weatherhead Foundation gave an initial endowment of $3 million to the University of Texas Medical School for the establishment of a center for the prevention and reversal of coronary artery disease.
I had got together a magnificent group of people globally who were committed to Lance Gould, who were committed to reversing heart disease, who were committed to PET scanning as the choice of procedures. And we got, everybody then became involved. In 15 months, I think we raised $11 million. And now, you see, the world is beginning to acknowledge that, yes, this is the best method of treating heart disease.
Although there are now innumerable studies and trials that point to the effectiveness of altering lifestyles and lowering cholesterol, the approach is largely overlooked by mainstream medicine. This kind of patient-centered treatment, with time-consuming consultations and long-term management, runs counter to the current trend in American medicine, where the emphasis is on high volume and quick fixes. As an example, only a small percentage of Americans with coronary heart disease are prescribed cholesterol-lowering drugs, even though there is overwhelming evidence that they can drastically reduce the number of heart attacks.
50 or 60% of what we're dealing with on the acute side could be prevented.
Cardiologist Lynn Schmaha is past president of the American Heart Association.
What we know is that if a patient has a high cholesterol, or even a slightly elevated cholesterol, not atrociously high, that giving them statin drugs reduces their cholesterol, the bad cholesterol, by 25 or 30%. and it concomitantly reduces their morbidity and mortality between 25 and up to 37%. A 37% reduction in my chance of having a heart attack if I had a high cholesterol is an amazing degree of progress. And we know it works in controlled studies. The problem is that of the patients, of the people in America that should be getting those drugs, probably only about 20 or 30% are actually receiving them. There's no reimbursement in most health insurance plans for the medicine or for the preventive visit.
Science is important, but it's not sufficient. We also have to have reimbursement. We doctors do what we get paid to do. We get trained to do what we get paid to do. And it's not because doctors are only interested in money, but they have to make a living. And so if you get paid $40,000 for a bypass or $20,000 for an angioplasty, or you prescribe cholesterol-lowering drugs, which are generally covered by most insurance plans, but lifestyle changes are not, and you really can't even bill for them, or maybe hardly anything, if that, then it's only natural to gravitate to those procedures that are reimbursable.
Our reimbursement system is procedure-driven. You make a lot more money as a physician if you do something with a procedure than if you spend time with a patient. This just didn't happen during the managed care environment. It started way back in the 60s. In the case of heart bypass surgery, we jumped on it big time. Other countries, Canada, Great Britain, France, they were much more reluctant. And even now, it is much more difficult to get bypass surgery and complicated heart surgery in other countries than in the US. So the good is we can get access to this very quickly. On the other hand, we spend 14% of our gross national product on healthcare, where the average European country spends 10%.
There is no doubt that bypass surgery and angioplasty can save lives. In past decades, they were the only effective treatment option. Americans annually spend more than $37 billion on these two procedures. Despite their high costs, they are covered by almost all medical insurance plans. In the United States, cardiac care has become a major growth industry.
Absolutely. We've developed our whole infrastructure of our most expensive part of our health system around these kinds of procedures. Our hospitals, which are so closely intertwined with our surgery-based heart teams, depend very critically on these complicated procedures as their bread and butter. When you've learned to do a particular procedure and you've developed a whole industry around that, they'll just not going to wake up one day and say, oh, well, what I've been doing is useless, I'm going to switch. On the other hand, it would be a mistake to think there's any vast conspiracy out there. I think there is, on the one side, a natural conservatism on the part of the medical system, as there should be, that just because somebody has come up with a new whatsy-dutsy technique doesn't mean they immediately have to jump on it.
There's some evidence that these deposits can be diminished in size so that the vessel might open up again, but that's a gradual process and may not occur in time to prevent a major heart attack.
What we know, kind of in the academic edge, the research edge, the frontiers of medicine, what we know that works clinically now has not yet quite spread far enough that in routine practice it is accessible or usable. So we're in a transition stage where the science is unquestionable, the clinical outcomes are unquestionable. It's simply at this point a matter of education, of exposure, of showing people what it means.
It's been a learning experience for all of us. I have
Edwin Ferguson is a physician in the Preventative Cardiology program at the University of Wisconsin Hospital in Madison. He has a unique perspective of coronary heart disease. He's been a patient of Dr. Gould since 1994. Like most patients in the program, he was looking for alternative treatment options for his own coronary heart disease. His research led him to Dr. Gould.
The PET scan was clearly positive. Well, it scared the heck out of me. You know, here I was with a young son, 7 years old, and I'm a human being. Just because I'm a physician, I'm no different. And I had the specter of having a heart attack and not surviving till I was 16. I was 49 at the time. That's pretty young. But I was scared to death, and Dr. Gould's a very fatherly figure. He kind of sat me down and said, this is what we're going to do, son. Which was actually what I wanted to hear. I wanted to have some guidance. What I would like to do is double the Zocor dose to 40 milligrams. That's still very safe.
Today, Dr. Ferguson is completely symptom-free. At 55, he regularly runs marathons. To his patients, he's both doctor and role model.
With this whole program, about 2.5 years, I went back, had another PET scan, and it had dramatically improved. The blood flow in all the areas of the heart muscle improved, so the scan dramatically improved. I had no symptoms. I began pushing many marathons. Felt great, had a real positive uplift. This program actually works.
Edwin Ferguson sends his own patients to Houston for PET scans before helping them design their treatment plans.
I think this program saved my life. I needed somebody to tell me what to do to get on the right program. This program was not widely known in '94. Most preventive cardiology units like ours here at Wisconsin are now doing this. We're pushing a very aggressive diet, exercise programs, very aggressive drug therapy. We want to normalize all the numbers. And we have outreach programs and numerous educational programs trying to teach physicians how to do this. So I very much support Lance Gould's program. He's been a real pioneer, and he's just, I think, spreading the gospel, and hopefully more doctors will get it and more patients.
There are signs that the new approach is gaining acceptance. In addition to Houston, 9 other PET centers offering reversal treatments have opened around the country. A growing number of insurance companies are paying for PET scans, and Medicare is considering approving them for reimbursement. In addition, several new non-invasive imaging tools are becoming available for diagnosing coronary heart disease in the early stages.
Deep breath in. Let it out.
One type is known as the heart scan or coronary artery scan. It is based on the familiar CAT scan technology and detects the presence of calcium in the coronary arteries. Calcium buildup is usually associated with cholesterol deposits and is a fairly good indicator of blockage in the coronary arteries. This type of imaging is often referred to as fast CT, since the CAT scans must be taken at higher speeds to avoid blurring caused by the motion of the beating heart. The latest screening tool that is just becoming available is the HeartView. This is another fast CT type scanner, but has the advantage of being able to detect soft tissue deposits in the coronary arteries, not just calcium. All of these technologies have the advantage of being non-invasive, but still fall short of the accuracy of the PET scanner. PET scans have the advantage of demonstrating the actual blood flow to the heart and revealing the ability of the coronary arteries to respond to stress. Acknowledging the potential cost savings of lifestyle changes as opposed to surgery, Medicare is funding a study with elderly patients to see if Dean Ornish's nutrition and exercise program can work on a large scale. A number of insurance companies already are reimbursing patients who sign up for his program as an alternative to surgery.
We saw this as an effort not only to improve the health of the patient, but that patient also can live better in terms of his overall functioning in society. That pays dividends to the insurance company if it works down the road. And we're fairly well noted as being one of the leaders in new technologies and new investments in the approach to medicine. And we thought it was an appropriate thing to try. We've been pleased with the outcomes, and it looks like it's going to be for real. So at least right now, I'm very optimistic about the program.
You know, the first 200 patients who've gone through our program at Highmark, only one needed a bypass or an angioplasty. It's extraordinary. So I think as we change reimbursement, as we show Medicare that these approaches are worth doing, I think it'll become the standard of care in a relatively short period of time. I think we've reached a critical mass here.
It strikes me that there is a movement in the direction of improving health, improving lifestyles, adding reimbursement mechanisms so that we can enable these things to move forward. I think that we're beginning to realize as a country that this is an epidemic that's coming. And if we can figure out how to pay attention to curing it or preventing it before it happens, it's a lot less expensive than it is curing it with an angioplasty or bypass surgery.
Lance Gould is at the forefront of a revolution in the treatment of coronary heart disease. It's a transformation that involves doctor and patient alike, and it has the potential to change not just the practice of cardiology, but the economics and politics of the entire healthcare system.
My role is to get it started, to show how it works. Other people see how it works. They make more centers. So it's you might say, a seed center, a demonstration center. It's the people that prove that it works. That's the real power of the center. They live. What else can one say? That's the best example I know.
For more information about alternative methods of treating heart disease, visit To Heal a Heart at PBS Online at pbs.org. To order a VHS copy of To Heal a Heart, call 1-800-364-8200 or send $24.95 plus $5 shipping and handling to the address on your screen. Major funding for To Heal a Heart is provided by Universal Computer Systems, with additional funding from Rensis, providing PC and audiovisual technology rentals for special projects, trade shows, and disaster recovery services.
This is PBS.